Hello, everyone. Welcome to the Bridging Research and Practice Conference. I'm Constance Kim with SHARE. Very happy to be here. It's nice to see everyone. This session is overcoming barriers to workplace success in the mental health system. And our presenter today will be Stephanie Ramos. Stephanie Ramos is the Communications Director for Cal Voices. Over the last 16 years, she has served as Youth Advocate, Family Coordinator, Director of Education, and various other roles. She has facilitated numerous focus groups for peers and works with employers across California to implement and improve peer support programs. We are so happy to have you here with us today, Stephanie. All of today's events are being recorded and they will be available. So if you would please, everyone, leave your name and contact information, email in the chat, and then we will be sending you an evaluation, and also you will have access to the recording and the materials. If you have any questions or technical problems, please send me a note directly in the chat. And everyone, if you would please mute yourself now and remain muted unless you have been called upon to speak. I am so excited to welcome Stephanie, so thank you.
Thank you, Constance. Good morning, everyone. Thanks for picking me. I know there was a lot of options to pick from when it came to the workshop, so I feel great to have so many people in the room and probably a lot of experts on the topic that we're going to be talking about. So a little bit about the agency I'm from. I work for Cal Voices. We're a nonprofit and we are an affiliate of Mental Health America National. We're founded in 1946 and we're the oldest continuously operated peer-run advocacy agency in California. We have over 78 employees and 98% of those employees have personal lived experience as a consumer of behavioral health services, or they're a family member of a consumer. So in my case, I'm a sibling of an individual who has at times severe mental health challenges, and I've been involved in navigating services for her, helping her advocate for herself, living with me on and off. And so that's definitely what kind of keeps this work near and dear to my heart. We have over 15 programs that provide direct peer support services. We also have some state and local advocacy and public policy programs. And through our training program, we provide education training. We also provide technical assistance and coaching to individuals, to agencies, to various employers in California's public mental health system. And so we'll tell you about our mission. Cal Voices is dedicated to improving the lives of residents in the diverse communities of California through advocacy, education, research, and culturally relevant peer support services. And in all of our programs, we work with individuals and families with mental health challenges to promote wellness and recovery, prevention, and improve access to services and supports. So peer support is really kind of what we do, right? It's like the main, I think, piece of work that we've done for many, many years. And we have peers in different roles. So we have them in wellness centers, we have them on phone lines that we operate. We also have them embedded in clinical outpatient programs. We have peers within clinical programs at Kaiser, within counties. We also have peers that are embedded within inpatient settings, crisis stabilization units, on mobile crisis teams, really working in a variety of environments. And, we know that peers sometimes may work on site with a peer-run agency. They might work within an organization that provides kind of clinical services and embeds peers. And then sometimes we're kind of out in the field, right? Or maybe I'm employed by an agency, but I'm working within law enforcement, or I'm working within another health facility. And so, our environment has a big impact on, creating or kind of mitigating some of the barriers that we might experience. And I think for the peer role, there's very unique things that we experience as challenges when it comes to really being successful in our role and really making a true career out of peer support. So who am I? My name is Stephanie Ramos. I'm our communications director at Cal Voices, but I get to work on a lot of different projects. Like in my introduction, I Have been here for 16 years, started as a youth advocate. I've supervised peer programs, and just really worked in a variety of different peer roles within the organization since I was just a wee young thing. And again, I'm a sibling, so that's kind of where my personal lived experience comes from. And I will say my personal lived experience has continued to evolve as my sister's recovery has evolved. So I'm learning along with her. So I know most folks have put their information in the chat. So if you have not yet, let us know your name, your role, what county you're from. I'm just going to be peeking because it's helpful to me. I'm like, oh, if I see a lot of certain positions in the chat, then I want to make sure that I might speak to certain issues as we go through the information. So as part of our training kind of arm of the organization, we call it WISE. So some of you might be familiar with our WISE program. We started that program in 2000, I want to say January of 2015. And we really started with actually focusing on employers. So we had a grant through the Office of Statewide Health Planning and Development to provide training and technical assistance to peer employers. And how we started the project was that we started with a bunch of research. We created surveys, and I know everybody's like, oh, another survey. And during that time, we also got a second grant where that grant was dedicated to the peer workforce. So providing trainings for peers that are working within organizations, doing monthly webinars for them around learning, webinars around really allowing them to support one another. And then we were also doing coaching, mentoring, and we were doing focus groups. So with those two grants together, my colleague and I would go out to different counties throughout the state, different community-based organizations, peer-run agencies, and my coworker would meet with the leadership within the organization. So she would meet with their agency director if they were available, their program directors, their managers, their supervisors, things like that. And then I would be meeting with the peer staff and just the peer staff. And we would both be having conversations with both groups of people. She would be finding out what challenges were employers having, what is it that they didn't know, what concerns that they have, like kind of really giving them a safe space to talk about the stuff that maybe they weren't comfortable talking about, or they were afraid to say or afraid to ask. And then I would be in the room with peers finding out, like, what is your experience? Like, what's working, what's not working? What are the barriers you're experiencing? And then we would come together and kind of talk about, like, what were the things in common as far as that they were bringing up as issues? Where were the needs for training? Where were the needs for coaching? What tools did the employers or the peers need? And so over, a few years, we were able to collect a lot of information around what the needs were, what the barriers were. And then in the years following that, we were providing additional grants that did similar work, but then we also had peer training and placement programs. So we were taking all that knowledge that we had learned with the research that we had done and really started creating a full peer training academy so that we were preparing peers, at least on the training side, and doing some coaching and mentoring to make sure that they had what they needed in order to be successful in their peer work. So let's talk about it, right? A lot of the barriers that we experience in the workplace or challenges that we have in the workplace can impact our self-confidence, right? I mean, we might go in with a certain level of confidence, and we might also, due to our, working conditions or things that we experience at work, it can also dent our self-confidence, right? And personal empowerment, especially, having lived experience, that personal empowerment is huge, right? Feeling like I have a voice, feeling like I can make a difference, feeling like what I do matters. And so all of those things can be nurtured, right? Or they can be harmed within the workforce and within the work that we're doing. So the common challenges that we're going to go over are role confusion, stigma, isolation, cooptation, and working conditions. And these are some of kind of the main things that came up during our key informant interviews, our focus groups, through trainings, through the coaching, like common themes that kept coming up that we felt were these challenges that peers are experiencing, but there were also challenges that the employers were experiencing that were impacting the peers. So we're going to go ahead and start with role confusion. And this is around the peer role in general, right? Sometimes when, and I think this is happening less and less, but when peers were entering the workforce, there weren't clear trainings around what the role was. There weren't clear guidelines within the workplace around what the expectations were. Maybe I'm working with somebody who has a similar role as me. How is my role different? Maybe I have two supervisors. That's something that we've seen come up a lot. And not knowing like, well, what is my role? Because this person is telling me to do this, the other is telling me to do this. The other thing that comes up with role confusion is the desire to fit in. I want to be accepted as a member of the team. And that's something that I experienced as a youth advocate as well. I was the only peer on a team of clinicians. I was very young, I was 19. It was a children's program. And I had the need to fit in and to be accepted, to be like, I'm a professional too. And so I started adopting clinical language. So in the meetings, I would be using clinical terms. And it was really coming from my need to be accepted, right? My need to be seen as an equal member of the team. And what I realized later was, it wasn't my role to take on the clinical language. It was my role to model the recovery oriented language. And so sometimes our desire to fit in can create some confusion within our role, because even though we were hired to be peers, everybody wants to be accepted, right? And so sometimes we kind of fall in line with what the norm is. Another issue that comes up around role confusion is handling transitions. And this is where a peer may go from a recipient of services to a provider of services. And this can be challenging for the peer themselves. It can also be challenging for the coworker. We see different transitions where folks are going from now not only recipient to provider, but now from client to coworker, right? Or now from I was an acquaintance of somebody and now I'm a mentor. And so those roles can be confusing for people, right? So my role with as a team has changed. How I use my lived experience and disclose that has changed. And it can be confusing not only for the peer, but the people around us, right? So if I, was in part of a clinical team, and now somebody that I know used to be a client or a consumer in our system is now my coworker, or is now my employee, being able to know those boundaries of, I'm not their clinician, I'm not their caseworker, they are now they're an equal to me, they're a team member of mine, and now I have to treat them like a true coworker. And so that can be challenging for the individual who's in that peer role, but also for the folks that are now working with them. And then sometimes we have individuals come into, programs that are now working in peer roles. They may be volunteering, they may be, working full time. And maybe they used to be an acquaintance of individuals that were service recipients, right? Maybe they weren't even receiving formal services at the same place, but maybe they went to the same wellness center and would see each other at groups or things like that. And now they're in a peer position, right? And that can be, again, confusing, right? So recognizing there's different boundaries now when I'm interacting with clients that might be coming in. I am just in a different role. And so that can be difficult. It can be challenging for folks when those transitions happen. So a quick review. So what's a peer, right? So we have lived experience of recovery, and within peer support, it's about that relationship of equals. We share our story, we inspire hope, we mentor and we role model, we model recovery. We're not a friend, right? We're supportive, we are coaches, we're a lot of things, but for the individuals we're supporting, we're not necessarily kind of like the definition of a friend. We're also not a clinical treatment professional, right? But we are engaging in reciprocal mutual relationships. We're non-clinical and we're not judgmental. Peer support's voluntary, non-coercive, and that's something that sometimes if we're not solid in our role can be confusing as well. So we may have a team that may want us to, we really need you to get this individual to sign up for this housing program. We really need you to get this individual to stop doing this certain behavior. But as peers, our role is not to make anybody do anything, right? It's non-coercive. And so that can be a challenge, sometimes some role confusion there where my manager or my team is telling me I need to do this, but I know I'm not supposed, my role isn't to make anybody do anything. So not only does that role confusion happen with us as the peer, but it can happen with the managers and supervisors, really having confusion around what the role of the peer is. We're client and family driven. We identify many pathways to recovery. And a big part of our role is advocacy and empowerment. And I think that that's important to note because we've seen over the years, sometimes the advocacy part of peer support is somewhat pushed to the side, and not by the peers, but sometimes by employers, their supervisors, sometimes other professionals that are working with them, and that they may not know or recognize that advocacy is part of the peer role, right? So it is part of our role to sometimes push back. It is part of our role to represent the voice of the individuals that we're serving, not necessarily the perspective of the programs that we're working in. So that can be another place where role confusion comes up, but really it's not really understanding what the peer role is. So when we talk about overcoming role confusion, some of the things that we've identified as far as helping address that is really understanding the principles of peer support and key recovery concepts. And that's both on the peer side and the employer side, right? So if we're a peer, we really understand the principle, what makes us a peer? What is the evidence base, right? And what are recovery concepts that we should be kind of abiding by and reinforcing when we're working with individuals in the community? And for the employers, the same thing, right? Understanding what is the peer role. It's very unique and specific, and are we utilizing it the right way within our programs? And how are we honoring those recovery concepts, really with all of our staff, but especially with the peer? As peers, we want to ensure that we're modeling recovery at all times, right? And that's a hefty load sometimes if we're working really hard on our recovery, but also working really hard in our program and ensuring that we're providing the best services that we can. But again, we're modeling in a lot of ways. That modeling can help kind of reduce the role confusion with maybe our older acquaintances, folks we maybe we're buddies with when we were working within the system or when we were receiving services within the system. But also modeling recovery is really showing our team members, our supervisors, our managers that this is really a key component of peer support, of how we're using our lived experience of recovery to support other people. We want to ensure that we're maintaining appropriate interpersonal boundaries, because that role confusion can slip up really quick. Are you my friend, or are you my peer? Are you my coworker? Or are we ensuring that we're being treated as coworkers, right, and not as like a client if we're a peer? Are you making sure that we are having one relationship with an individual that we're supporting and avoiding any dual roles? We want to educate other people about our role. And that's something that I think is, sometimes takes some courage. If we, haven't felt as an equal member of the team, we want to ensure that that folks understand what we do and why it's important, how it contributes. In some of our programs, our peers may work as part of a clinical team, but they're the ones in charge of doing the orientation for the new person that comes in, right? Or when we have new team members come on, the peers are part of orienting that new staff to the team so that they understand what the peer role is. It may be the peer team doing a presentation to the whole team to go over like what their core competencies are, what the things that peers do and don't do within their role. So that's going to be really important. And sometimes we have peers working within the system, and it's not that folks don't want to value them. It's sometimes they just don't know what peers do. So maybe they're not utilizing them to the full extent. They're not seeing actually all of those powerful tools that the peers bring to the table, how the peer role actually helps the other team members be more effective in their job working with individuals. So that educating your team members is really important. And then reviewing your job description. And this really goes for everybody. And at some point you might be like, oh yeah, you have a job description, but when's the last time you looked at it? And that's something that, I have to ask myself that here and then. Like, I need to pull my job description out and look at it, because how do I know if I'm doing my job? So we're like, oh yeah, well, I'm doing peer support, but there may be specific things in your job description that you are responsible for or should be doing. And it might also help you, again, like kind of stay in your lane. Like, what's my role as a peer support worker in this particular program, right? And that might be different than in other settings. So you want to ensure that you are reviewing your job description. And that really goes for everybody, regardless of what role you're So I just wanted to open it up to the group real quick. Just is there, have you experienced any role confusion? What did that look like? And have you found any strategies that have helped you in kind of ironing that out with either your team, yourself, or other individuals you're supporting? And I know we have quite a few people. So if folks want to jump in and maybe keep it to a minute, I'd be happy to hear from folks just to see what your experience is.
Hi, yes, my name is Joanne West Point and I'm with LA County. I work with an interdisciplinary team. There's one peer, which is myself, and everyone else is community workers trying to do the same role. So I've been in a big fight, okay, trying to utilize these competencies in such an environment like that. But I know change is going to come. So thank you.
And that role confusion is real, especially when we're working with community health workers, because I've heard a lot of times, oh, well, you guys do the same thing.
Really? I'm still confused.
I know, right? But how we do our work is very different, right? Because we're really incorporating our lived experience into the things that we're doing. So, we might have a community health worker that's linking somebody to a program. It's like, oh, I found this great program. They do these things. As to a peer might say, you know what? When I was getting services, I found this one program really helpful. And here were the things in the program that I felt helpful that supported me in my recovery. So how we're doing it and utilizing our lived experience in doing our work is really important and differentiates us from other really great individuals that are working within our programs.
I agree.
Yeah. So I see John has his hand up.
I believe it's John Bokanovich, if I pronounced it correctly.
Good morning, everybody.
Good morning.
Thank you for taking my question. So I work in a substance abuse program, and we're just in the process of hiring peer support and recovery support workers. What is your understanding of a person, or do you know the answer to this? Can a certified substance abuse counselor work as a peer support in the role of a peer support person?
So when we think about, providing peer support in a way that's evidence-based, it's about doing the best to match our lived experience, right? So I'm an individual who's a family member to somebody who has challenges with mental health. My ideal peer is going to be a family member of somebody who has mental health challenges, because I'm going to be able to share, we're going to be able to connect on our worries, our concerns, our challenges, what's worked. Am I doing my self-care? We're able to connect on those things. So ideally, an individual who has, recovery from substance use, their ideal peer is going to be other individuals who are experiencing challenges with substance use, because they can share what worked for them. When I was, having, getting a little tempted, or I was in this difficult environment and I wanted to use, here's what worked for me. So making sure that the lived experience that they have is going to connect with the individual and the challenges that they're experiencing. And the same the other way, if I'm not going to be the best family member to a family member who is having somebody with substance use challenges, because I don't have family members who have that issue. So I can't speak to, your family member keeps saying that they're, not really drinking that much. And then at the holiday party, they had a big blowout and got arrested because they've been drinking. Like I'm not going to connect in the same way because I don't have that experience. So I hope that makes sense, but really trying to ensure that we're doing our best to match the lived experience so that the tools that we're sharing, the hope that we're sharing really connects with the experience the clients that we're serving have.
Thank you.
Adrian?
I thank you for calling me. Yes, I not only did I work here at Campo de Oro, but I work at also too at a residential program, and I feel that a peer role has a lot to do with leadership and because over there at the residential program, you got guys that they got mental health issues. You got guys that are still struggling. And so what I think about that is that I try to give them the best support that I can. The best, because from my experiences, I talk to them and I always encourage them that there is hope, you know what I mean, in their sobriety, because a lot of well, it's a men's place. A lot of gentlemen there that they just like sometimes they lose hope, and so I gotta keep. I feel I gotta keep them balanced up. You know what I mean? Because if you watch them and they have their head down, something's going on in there. You know what I mean? So I feel that's my job to, as a peer role, to engage with that person and try to give them the best information I can from experiences that I've had. You know what I mean? And a lot of times it works.
Absolutely. Yeah, that like hope is the catalyst of recovery, right? And I think that
Right.
when we talk about, peers as leaders, so it's of course like, lifting people up, giving them hope that their future can look different. And also one of the things that we see as really like a key component of peer support is the helper principle, right? I am, in some ways enhancing my own healing, enhancing my growth by providing support to other people. And as leaders, we actually have the opportunity to foster that in the individuals that we're supporting, right? So if I'm working in a residential program, how am I creating that opportunities for them to support each other, to provide hope to each other, to do those things so that they're now also finding growth and healing and all of those things by supporting each other, right? So it's when we're leading, we have so many opportunities to build that foundation within the folks that we're serving and knowing that it is going to enhance their growth, right? Their commitment, and maybe kind of making our future peer workers at the same time. So let's see, Vanessa, and then I'm going to take us on to the next challenge.
Thanks, Steph, and thank you to everyone who's contributing. I love the model of recovery at all times because I think that's been, for me, like something that even though like my roles may be growing or whatever the case may be, I think it's important that I model that recovery, right? And that I am able to set those boundaries, right, in a respectful way, or just like, take a wellness
Hearing
break.
other voices, Vanessa.
Oh, I'm sorry. I'm in a shared office space. Can you hear me? No, is it distracting? I could put it in the chat.
Right.
Okay.
Yeah, if you can put in the chat. Yeah, only because it's a
All right,
couple
Steph.
voices going on. Thank you so much, though. I appreciate it.
Yeah.
All right, I'm going to keep us rolling. We have 4 more to get through, and I want to make sure we get through it, but also give you time to contribute as we go. So the next challenge, I'm sure many people are familiar with, is stigma, right? So within the workplace, there's different types of stigma that we might experience. Some of it is really obvious, some of it is smaller. Some of our workplaces do a really good job trying to address it, but it can still kind of be underlined in there. And the first type of stigma we may experience is mentalism, right? And mentalism is another ism, right? Where we're being treated differently based on having a mental health challenge. And we see it all over the place, right? Like we see it in the media and how individuals with mental health or substance use challenges are talked about. We see it within movies, TV. We also see it within, different communities, right? Where, oh, you don't need to go see a therapist, right? Or, oh, that's, those are the crazy people. You don't need that kind of help. We also have it within ourselves, right? Mentalism, where we might talk about ourselves in clinical language or, really kind of put those labels on ourselves. So mentalism, like other isms, is really an impact individuals with lived experience working in our system. We might also have experienced macroaggressions. So these are overt, they're obvious, they're easily identified by anyone who witnesses them as kind of unfair, biased, or discriminatory. We might experience microaggressions. So these are subtle, they're not obvious, they're hard to point out. And sometimes folks may act or do something that's a microaggression and not even know it, right? So these can be subtle things that people say. When we sometimes microaggressions, when we think of them, someone's walking down the street acting odd, we go to the other side of the street, right? So little things kind of showing somebody that this isn't, I'm not that comfortable with you, or I don't like something, and that kind of message energy is put out there. Another stigma that we experience is low expectations. And I know folks might not always think of that as stigma, but there are myths about peer support that keep peers trapped in subordinate, low-level positions and really prevent them from fully contributing and reaching maximum potential. And that is something that we've seen in many organizations throughout the state, right? Like all of a sudden we got to hire peers. So, oh yeah, we can hire them, but we're gonna, have them file work, or they can serve meals or take people to appointments, or in one county, even wash the county cars. So, the low expectation is definitely something that we see kind of under the stigma lens within organizations, and it can create feelings of hostility from other staff who think peers get a free pass. Right? Like, well, why do they get an office next to me? Why aren't they in a cubicle? They can't really do anything, right? So we can kind of get that hostility from them. And it really reinforces stereotypes behind, and around the peer role. We also see more marginalization. And so this is when we're placing peers in marginal positions, their role is diminished. They're seeming unimportant, not giving them any roles for influence or power. And so that being marginalized is something that we've seen, I think, as the peer movement has become kind of larger over the last few years, especially with certification coming out, we're seeing less of that, but it is still happening, right? It's like, oh, we hired them, we'll have them go make the coffee, do the coffee cart, do things that maybe aren't as meaningful. And I also want to clarify though, I think even these kind of minor roles are still also important and stepping stones for folks to get into peer roles, right? So I always want to say there's room for everyone at the table, and ensuring that we have those different levels of service to provide with people, but not kind of lowering that bar and limiting what our capability is, and ensuring that those stepping stones are there, but we're also creating roles for peer professionals within our system. Tokenism is another issue that comes up, and this is the practice or policy of making no more than minimal, symbolic, or superficial efforts to offer opportunities to minorities equal to those of the majority. So checking the box, right? Well, we had to hire a peer, we hired a peer. And so, it's, are we really investing in our peer workforce? Are we finding meaningful roles for our peers? With going back to the myths, there's a report that was put out by RAND earlier, actually a few years back, and they identified some common myths within our behavioral health system. And some of those myths are that peers can't work full time, that peers can't provide mental health services, that peers will relapse, that they're too fragile to handle job stress, that they can't handle the administrative demand, and that peers will cause harm to clients that professionals have to undo. So these are real myths that are out there. The report that RAND put out, it's actually a guide for clinicians. It identifies these myths, and then it also has rebuttals for each of these myths. So maybe Constance, when I send the PowerPoint, maybe I can send out that RAND report to you as well, and we can email it out as a handout. Yeah, it's a great, I'd say it's a great tool for you to look at, but also share with your teams, right? If you're explaining your role, if you're educating people on the peer role, not only going over your role, but also saying, oh, and here's this guide for clinicians around peers and the misconceptions that are out there. So when we're overcoming stigma in the workplace, again, we want to be modeling recovery at all times, right? And that is, I think there's a lot of pressure on peers in the workplace, because we are sometimes only one or two positions representing a whole field of work, representing a whole peer workforce, just my one position. And so sometimes peers are kind of under a microscope, right? If I do really good, then sometimes I'm the exception. Like, oh, well, you're not those peers, you're, special kind. Or if I perform poorly or make a mistake, it's, oh, well, see, that's why we don't hire peers. So as peers, we need to ensure that we're modeling recovery at all times, right? We're reinforcing the peer identity and the strength that we bring. And we're also showing our colleagues, our systems, that the individuals you're serving can and do get better. And in fact, they could provide support and services like I do and could contribute to the team like I do, right? So we're really kind of changing how our system thinks about and treats individuals that are working on their recovery. We also want to raise consciousness about stigma within our workplace. So it might be naming mentalism when it happens, strategically responding to stigma, whether or not it's intentional, and informing and educating other people about our role. And with raising consciousness, I also want to say, do it safely. So I might be here saying, well, make sure you respond to that stigma and you name that mentalism. And you might be sitting there like, well, I kind of want to keep my job. Right. So there might be some workplaces where it's not safe to do that. But there might be workplaces or coworkers that it's safe to kind of start having those conversations, mentioning that you noticed something and it seemed a little off and you want to talk about it. Also, part of overcoming stigma is supporting and validating one another, right? So, and this assumes that there's more than one peer in the workplace. And so, and I actually want to say it's really important that peers have another peer in the workplace, because sometimes we're in a very unique role. We could be in a marginalized role, and not have anybody else to kind of confide in. Maybe you went to a meeting and something got said that was really off-putting to you, and you're kind of like, did they just say that? But you don't have anyone to connect with, right? To kind of talk it through. And so if we have other peers in the workplace, creating an opportunity to support and validate one another is really important. So I just want to open it up again, just briefly. What have you found helpful as far as overcoming stigma within your workplaces?
Leaving. Like leaving unhealthy workspaces. And yes, seriously, like doing it responsibly, but like leaving and like, finding work for, and like through supporting peer-run organizations, like just make, like we vote with our feet, like just not standing for it.
Yeah, it takes a lot of courage. I think, Vanessa, that is, I think a lot of people would be scared to say that, but I think it's real, right? Sometimes we have to put our mental health first, and that means going somewhere else. So absolutely. Thank you. Let's see, Tiffany.
Yeah, I just wanted to mention that part of this is also there's ableism that happens, and especially when there's things where you have comorbidities, you have physical and perhaps psychological disabilities, and in accommodations, reasonable accommodations. And so that can also be a part of it. And having, like I think it was Vanessa was saying, having that kind of a supportive workplace is really important, and leaving if it isn't, because nothing's worth our mental health, and our physical health.
Absolutely. Let's see. I see another hand raised, but there isn't a name. It's the TPLE pot.
Yeah, this is Elizabeth. That's Transforming Peers' Lives. We're in Ventura.
Awesome.
I'm really enjoying your training. This is going to be really helpful in our county. I'm just kind of reinforcing key points. So one, not where I originally received my peer training, which was in New York, but in the behavioral health department here in Ventura, most of the people that are working as peers actually seem to relish that there's low expectations and that they need to take breaks, and they're not really expected to know things, that they really buy into the medical model, which is part of why I started this alternative peer group and got the EPIC grant. So, that can be really challenging, especially when we're talking about supporting one another, because when I come in and really question that and want high expectations and show our value and make sure that when they're doing orientation, they actually know what they're talking about, that's very threatening to people that are used to kind of coasting and being perceived to like needing a lot of breaks and taking walks versus kind of doing work, right? So do you have any comments on that?
Yeah, so that I want to blame on our rollout of peer support in our behavioral health system, because initially, you know, when we were doing our focus groups and our key informant interviews early on in our WISE program, one of the things that we recognized is that a lot of people were hired simply because they would disclose their lived experience, not because there were other work skills.
Totally.
Right?
Yeah. For me, it's a training issue. Totally. It's
Yeah. And so I think that was, you know, I think a result of employers not fully understanding what the peer role is. And, you know, when the Mental Health Services Act, you know, passed and we started implementing programs, part of rolling it out was saying, hey, you have to have peers in your programs, but there was no guidance on, well, what does that look like? What do peers do? And so even though that kind of expectation came out, employers didn't have any support. And so that I think was one of, you know, kind of in a sense, a flawed rollout of not providing support on how do we integrate individuals with lived experience into our behavioral health workforce. So I think that that's where that came from, saying, you know, okay, we have to hire people with lived experience. You'll tell people about your story, you're hired. Not thinking about kind of the further implications of, well, how do you integrate that onto a team, right? And how are they providing professional services? And so what we've seen happen is now that is shifting, and you have, you know, individuals who maybe got hired on that now are being required to do other work that maybe they haven't been provided the support to build those skills yet, right? And so that's really scary now. Like, I got hired to do this work, I've been doing it, and now you're telling me I have to use an electronic health record. Now you're telling me, you know, I have to start doing these things in a very different way than I was and taking on a lot more responsibility, but that's not what you hired me for. And so I think now that we're starting to understand, and employers trying to understand the peer role more, I think the expectations, we're raising those expectations, but I think going along the way, supporting staff to meet those expectations, because I could think it can be very scary, right? To all of a sudden have to have all these skills that maybe we don't feel that we have yet. And then it's like, you know, we obviously, like, we get comfortable and it's like, well, why do I have to change? This is what they hired me for. But that often comes from not having the support to build those skills. And so again, I think flawed rollout, but also, you know, now that we want to change things, we also need to provide support for folks to build those skills to get there.
Because I think sometimes, you know, people get encouraged to take a job because they think, oh, it's a peer role. So they themselves kind of internalize, there's not going to be expectations on me. I can take sick days. Like, this is a great job because I'm not going to be held accountable or whatever. So I you know, I think we really internalize a lot of that, or many peers internalize a lot of that.
Yeah.
But
And then on the
great
employer,
points. This is really helpful, Stephanie.
and then on the employer side, you know, like, what do our job descriptions look like? Are they very thorough? When somebody reads it, do they be like, oh, I have to work on a multidisciplinary team, I have to do 4 support groups, I have to facilitate, you know, family team meetings, I have to, like, so it's also not just, oh, is it the peer role, but are our job descriptions and job announcements very clear in what the expectations are, so people have a better idea of what they're signing up for when they're signing up for that particular position. I'm going to keep us rolling. We have Adrian and then Ortiz, and then we're going to keep going on to the next challenge.
Thank you for calling by me. You know, at my my other job at the residential, I had that same issue, sort of, with a peer, and when I first started there, and then you got the ones that's been there for a little while, and like you were saying, some of them just like to just coast through, you know what I mean, instead of doing the job that they're entitled to do, that they're supposed to be doing. And so, but to me, I'm not gonna let a patient go without information.
Mm-hmm.
You know, I'm gonna help that patient, that client, any way I can. And so I used to have a little issues with an employer there, and I sat into one of his groups, and you know, when they're expressing to a client that and what is it? They break them down, you know, and in some group they break you down, but then they'll build you back up. You know, he was doing this to a kid, a young guy there, young man there, and I'm looking at him like, what's you know, why are you doing this? So I had to intervene, you know, and even he's my coworker, but I had to intervene because the simple fact that he's not building that client back up. He's not doing nothing, you know, he's making that client clam up more and have more weight on his shoulders, you know, and it's bad enough that the client has issues, you know, so, and there's other things that went on with this certain individual that that I didn't see. I mean, I couldn't agree or let it go by for the simple fact is because of the wrong interpretation that he was giving to the clients that are there, you know what I mean, the residents that are there. And that's not fair. That's, you know what I mean, because they're there for treatment.
Yeah. And
You
part
know,
of our role as peers is advocating, right, for the individuals that we're supporting. And so I think that that's important in those settings, especially that we're ensuring that we're providing a voice, right, for the folks that we're supporting. So I'm going to move us on to Ortiz, and then we're going to go on to the next one because I think we have about 15 minutes left, and I want to make sure we're able to get through all the content today. Thank
Hi,
you.
Stephanie, it's Migdalia Ortiz. My question is this: the peer support and being peer specialists have been in existence for decades. It started in the, I guess, in the beginning in the 70s, as I've become aware of. And up and I would say in the last 10, maybe 20 years, the healthcare industry has been focusing on peer evidence-based and peer support. Why is it, my question is this, why is it that there's still confusion in this particular field when there isn't in any other field that I know of? If, like, for instance, if you become a technician and learning how to repair computers, there's certain skills and training that you need. There's when you go for a job, there's a job description that the employer is expecting for you to know, right? It's the same thing in this as a social worker. It's the same thing as a RN, as a registered nurse, etc. Why is it that it's still confusing for an employer or even as a peer when it comes to their role and their responsibilities?
Yeah, so I think a few reasons. Peer support was around informally for a very long time, so not really embedded in clinical programs where now folks had to work alongside peers within like a healthcare setting, right? So it was around, but not really embedded in our healthcare settings. And then, like I mentioned earlier, it didn't really become like peer support was happening, but it did not become as widespread, at least in California, until the Mental Health Services Act passed. So we had peer support going on, but not at the level that it's going on now, because part of, you know, in the Mental Health Services Act, we are supposed to be employing individuals with lived experience in our behavioral health system, right? So it had been going on informally, and then it was going on kind of formally, scattered here and there. And then all of a sudden there's this requirement that, well, now you have to do it. So now we have this large influx of peer staff coming into our workforce, but there was no training, no support for the employer on, well, what does this role do? Like, how do they work as part of our multidisciplinary teams? What are the best practices? There were very few formal trainings available within California, even for peers, prior to that rollout. And so I think kind of like we got the cart before the horse, like we started bringing in all these peers without doing all of the preparation work that needs to be done before bringing peers on into our workforce, like ensuring all of our staff understand what a peer is before we bring them in and say, hey, you got to work with them. Ensuring that our, programming is recovery focused, right? Being driven by the individuals within our programs. Are we doing all of that work before our peers came in? And that's not what would happen. We brought our peers in first, and then we're like, wait, well, what do they do? How do we evaluate their performance? Well, you know, what are their performance expectations? So it's like we kind of, instead of being like, let's do this whole phase of preparation to bring in peers, we just brought in the peers, and now we're kind of starting to do all this work on the back end.
Right.
The other thing is that there weren't set standards across the state as far as what peers needed to do. So everybody was kind of doing it differently, and there wasn't this like clear, like if you look at other professions, it's very clear like what the scope of their roles are, what they do. There's a certain, and some of it comes with certification, right? There were these certifying bodies. Here's what the role is. Here's what the trainings need to be, all of that stuff. So it was already kind of set for employers when they bring those roles into their organizations. But for peers, that wasn't the case.
Well, I understand that, because what you're saying happened in New York, happened in Texas, happened in Pennsylvania, you know, but I think that when New York State, or here in New York City where I'm at, when they started really implementing peer support, they followed the other guidelines that were already established. Right? They followed the way the system was set up in Pennsylvania or in Texas, where they had peer certified, where they had the training, etc. Why is, you're mentioning in California, they went through that, and they're starting to enroll peers in the health field. Why is it that it seems like every state seems to be doing the same mistakes? And then when they bring the peer is going through the same challenges. It's like what you're telling me is no different than what I experienced or have heard here in New York.
Yeah, I mean, I think that's some of the frustrations that peers are having. So, you know, I work at a peer-run agency, and the whole time certification was rolling out, it was like, why aren't we looking at Michigan? Why are we looking at Pennsylvania? Why aren't we looking at, we're one of the last states to do this. Why are we not looking at what other states have done? Because they've already gone through the mistakes and fixing things, finding things and all that. So I don't know, but I will tell you, it is very frustrating. And I think that what you're talking about is, I mean, what a lot of us are experiencing now, and it doesn't make sense. I'm like, why recreate the wheel if this has already been done over 48 other times?
Thank you.
Yeah, I'm with you. All right. So what I'm going to do, because we have 9 minutes, is I'm going to get through the rest of the slides, and then at the end I'm going to open it back up, and then you can kind of jump in how you've been doing, letting us know, you know, how you've been overcoming things, what your questions are, things along that line. Does that work? I see a couple heads nodding. All right, let's do this. So the third challenge is isolation. So it's important to recognize that our sense of belonging on a team has a direct impact on our commitment to a task, a sense of role clarity, and how effective collaboration is. The other big implication of being isolated at work is that we increase our level of surface acting, or kind of covering. So we might conceal parts of our authentic identity, right? Who we are. And what happens when we feel lonely at work is that we may start to pretend to be someone else, right? Not let our true self come forward. And we might start to emotionally withdraw from other people. Like this is just work. I just go in, I clock out, like, so we don't have those connections, right? We're not getting maybe as deep or building those relationships that would lead to effective collaboration. So sometimes when we're thinking about isolation, there might be only one peer on a team or in a department, right? So not having that connection to another peer to, you know, if we're struggling with a certain issue, kind of having somebody who like feels our pain, is going through something similar, we can bounce it off and be like, is it just me? We might not be asked to share our opinion on a team, right? So again, kind of our experience is being isolated. Maybe we're not encouraged to participate. So it's an option, but they're not saying, hey, you know, Adrian, we really need you at that next meeting. You know, what you do really matters and helps. There might be lack of support for our role, right? So no one's advocating for us when decisions are being made. So maybe our, you know, and support could be a lot of things, right? Are we having opportunities for coaching, for mentoring? Do people care about what's going on? My experience at work, do they care about what's going on in my personal life? Do they care about or are thinking about my, career ladder? What does my career look like in the long run? So really not having support around the peer role, like compensation, right? Is that being advocated for? And then another part of isolation is that we might not have mentors or networking opportunities for other peers, with other peers. So that isolation piece can be really challenging for individuals, especially if we've come into this work with a lot of passion. We're really committed to this. I've been there, I want to help other people, and then kind of feeling isolated in the work that we do. So when overcoming isolation, we got to do our best to get out of our own head. Right? I mean, being in our own head is a rough. I don't know how many of you lay in bed at night and you start overthinking and it's been a half an hour. It's like, why haven't I fallen asleep yet? Too much going on in here for me. So we want to try to get out of our own head, really engage in self-care. And that doesn't mean like, go get a massage, but engaging in self-care. Like, what are we doing daily, right, to keep ourselves well in our workplace? Are we making connections? Are we doing, and like Vanessa said earlier, putting our mental health first. So how are we doing that self-care? Are we interacting or initiating interactions with other people, making small gestures to make connections, right? Like breaking that ice, taking down those walls, being human, right, with one another. Are we speaking up in group settings, right? Making sure our voice is heard. And that can take a lot of courage, right? If we have felt like our voice didn't matter, we're not invited, maybe we haven't had a lot of opportunities to speak up, so it might be a little nerve-wracking to do so. But part of peer support is ensuring that the individuals we serve, that their voice is at the table, right? So speaking up is essential to the work that we do. We want to seek out supportive coworkers. So even if we don't have other peers, do we have other allies, right, that get the recovery movement, that get what peer support is, that understand our contribution to the team and the individuals that we're serving. We also want to look at participating in group activities and community events. So if we feel isolated at work, we want to make sure that we're not feeling isolated outside of work as well, right? So having other things that support us, other things that are important to us, other things that we can do so that our whole world isn't focused around work, right? Because when that happens and work isn't going well, that's going to have a negative impact on us overall, right? So ensuring that we're, engaging in other interests outside of work, other things to fill us so that we're whole, so that one piece, of employment doesn't have such a negative effect. And we also want to find peer support from peers and other programs and other agencies. So, finding, are there peer networks in your area? Are there peer listservs that you can get on to connect with other peers? I know Disability Rights California just recently started a peer listserv for peers, at least in emails, right, to be able to kind of connect, share information. Cal Voices is going to be starting a peer association. So you might have gotten a survey from us recently. We'll be doing a webinar soon to really kind of get that collective voice and get peers together. In Sacramento County, they have a youth advocate committee and they have a family advocate committee on the children in the children's system. And in those committees, they bring all of the family advocates from all the agencies in the county, all the youth advocates from all the children's programs in the county, and they have monthly meetings, right, where they get together, they talk about what's working, what their challenges are, provide peer support to one another. They're able to get, have presentations that are relevant to their role to get the information that they need. And then they have an executive team where their division, the children's division chief, comes in and meets with their executive team once a quarter. So they're getting that feedback out there. But finding, what is your kind of support network that you have or that you can build or contribute to within, whether it's your county, statewide, just finding other peers that are out there that you can connect with. The fourth challenge I wanted to get to is cooptation. And this is the professionalization of the peer role. This is where we may be adopting values, attributes, and the styles of professionals or clinical providers. And it's sometimes a drift more towards the medical model. And this can happen, if if we feel like, oh, we don't tell our story, right? Or we kind of go with the flow because we don't want to rock the boat. We may use clinical language. Maybe we're not advocating for the interests of the folks around us because we're kind of taking on more the traditional model of how we provide services. Or in some cases, misusing our position with individuals to push a clinical agenda. And so in overcoming this, we want to ensure that we have a strong peer identity, right? So that might be creating connections with other peers to ensure that we're maintaining our peerness, working with or collaborating with or connecting with peer-run organizations where that's what they do and that's their focus. Trying to ensure we have more than 2 peers per program. Reinforcing and supporting the peer role, right? And a lot of that is going to come from connecting with other peers, or if there's a supervisor on here and you're really committed to the peer workforce, ensuring that we're reinforcing that role. Educating our clinical and treatment team so they understand what our role is, right? So we get to stay within our role. Creating career ladders for peers. So maybe I start as a peer and I want to stay a peer. So what's the next step? I don't want to become a caseworker. I want to stay a peer. So what's that next step in the career ladder when it comes to those peer roles? And then ensuring that we're using recovery-based language and really modeling to our team members that that's how we talk about the individuals that we work with. Working conditions that peers experience challenges around is low pay, non-existent or unaffordable benefits, job stagnation, so not really being able to move up or go anywhere, job insecurity, maybe I'm hired as extra help or a temp employee, and then there's other structural barriers that peers experience as well. So we want to ensure that we're engaging in training and skill building for ourselves, but also on the employer side, right? Are they getting the training they need to really understand the peer role and the value that it brings? Ensuring that we're engaging in professional development. So we're ready for that next step when it comes available, whether it's within our own organization or an outside agency. Advocacy. Right? Advocacy, finding a group of individuals that you can advocate with for better conditions for peers. Like I mentioned, we're going to be starting a peer association. I'll send that information as well. Hopefully we can get that sent out about our webinar. And then engaging in coaching, networking, career planning. We offer some of that through our WISE program, and I'll make sure I get you that link because we're almost wrap it up. I missed a slide. No, I did not. Okay, so our WISE program is a great resource. I just want to throw out there. Our website is wiseup.work. It's a place to start getting connected, but we are able to provide training, coaching, other information and support out there. We're going to be kind of expanding the peer support, the support for peer supporters in the next few months. And so we're going to be trying to get that information out to folks as well. So if you have any interest in kind of, hearing more about what we talked about today, getting more support, getting more connected with other peers, definitely shoot us an email. I would say probably the best email to email would be the info@calvoices.org on the slide. Shoot us an email, let us know you want to get more information, find out about the association, anything like that, and we'll make sure that you get information from us for our next webinar around the peer association and any kind of like webinars or coaching or training or anything that comes up. Someone asked the WISE website, it's not .org or .com, it's actually wiseup.work. I know it's a little different than what you're used to seeing. So it's just wiseup.work. And I know we're right up, it's 11:17 and I went over time. So I apologize for that. I want to make sure folks get their break. But I'm going to hang out for a minute. And then again, if you want to connect, you have more questions, you're looking for resources, you want to get on our distribution list just to get more information, shoot us an email at info@calvoices.org.
Thank you so much, Stephanie. That was amazing. And thank you to all those who attended. Please, if you haven't yet, please leave your email and contact information in the chat so we can send you a survey and all of the everything that was presented today. We are recording, so the recording will be available. And again, thanks so much, Stephanie.
Thanks,
that was
Deb.
wonderful. This room will stay open, and our next presentation will be at 12:30. So thank you, everyone.